In the clinical scenario, where the emergency pathway of the difficult airway algorithm has been entered, there are 4 basic procedures that will be used in order to resuscitate the airway. Attempts at face mask ventilation, attempts at intubation, attempts at using a supraglottic airway, and lastly, surgical airway techniques. But how do we make decisions in this high-risk and high-stress environment? And how do we organize our team at the pace of an airway code? Nick Chrimes and Peter Fritz of Australia have developed the Vortex approach, a cognitive aid to be used in this situation. In the Vortex approach, the clinician or the clinical team makes their best attempt at all 3 of the non-invasive techniques. And these attempts at intubation, face mask ventilation, and supraglottic ventilation can be made in any order. It may require more than 1 attempt at each technique, but something should be changed between each attempt. For example, the team should consider manipulations of the head and neck, the larynx, or the device being used. Consider the use of adjuncts, for example, oral and nasal airways, or a gum elastic bougie. Change the size and the type of the device being used. Consider using suction or muscle relaxants. In any case, no more than 3 attempts should be made to optimize each of the 3 techniques. Things are unlikely to get better, and it's time to move on. Why a vortex? Because with each failed attempt, you are spiraling into the inevitable 4th and last technique. That is the surgical airway. And you might exhaust all of your attempts at the non-invasive techniques and proceed with the surgical airway before the oxygen saturation falls. But what if things get better? What if the non-surgical attempts to oxygenate work and make the situation improved? You are now in the green zone. You're not done resuscitating this airway, but things are stabilizing and the team can step back and plan the next step. The second major function of the Vortex approach is team communication. When an airway resuscitation occurs, surgeons, intensivists, emergency medicine personnel, respiratory therapists, nurses, hospitalists, and anesthetists may all be in the team attempting to resuscitate this airway. All are working towards the same goal. Will they understand the ASA difficult airway algorithm, or will they understand the simplicity of the Vortex?